Okay, let's get started, everybody. Thank you so very, very much for joining us here this afternoon. My name is Joe Gogler. I am the Robert L. Kane Endowed Chair in Long-Term Care and Aging here at the University of Minnesota. I direct our Centers for Healthy Aging and Innovation and our Bold Center of Excellence in Dementia Caregiving. And wanted to thank you for joining us for this event. This event is hosted and sponsored by our Minnesota Geriatric Workforce Enhancement Program, funded through the support of the Health Resources Service Administration. And really the whole point of this event was to take the opportunity to answer some of the key questions you might have as someone living with dementia, as someone caring for someone living with dementia, or someone who's just concerned. So what we tried to do was essentially create a virtual geriatric multidisciplinary clinic for you to have at your disposal. And many of you have already submitted questions. I'm sure many of you will be continuing to submit questions throughout our event here today. Please use the Q&A function on your Zoom to do so, and we'll do our best to get to them. As you can imagine, we've received hundreds of questions, so it will not be possible for all of us to get to every single question. So what we tried to do is identify those questions that seem to come up repeatedly, that were most salient to both you, and also that our panelists could address effectively as well. What I'd like to do is actually have our panelists introduce themselves today. I'm just going to go across my screen. Let's start with Dr. Robin Birkeland, please.
Hi, everyone. My name is Robin Birkeland. I have a PhD in clinical psychology, and I work with Dr. Gogler. I do a lot of the intervention studies, providing the interventions.
Great. Thank you so much, Robin. And let's go to Robin Fraser next.
Hello, I'm Robin Fraser. I work with Dr. Gogler in the Center for Healthy Aging and Innovation, and there I'm the Associate Director of Equity and Community Engagement.
Thank you so much, Robin. Dr. Gustafson.
Hey everyone, I'm Allison Gustafson. I'm a physical therapist and also a clinical researcher at the Minneapolis VA.
Thank you so much, Allison. Dr. Busker.
Hi everyone, I'm Amy Busker. I'm a doctor of pharmacy with Fairview Partners in Geriatric Services, and I specialize in geriatrics.
Great, thank you, Amy. Jill Sigliana, please.
Good afternoon. My name is Jill Sigliana, and I'm an occupational therapist by background and the program director at Memory Care Home Solutions in St. Louis, Missouri. And we run a community practice where we deliver evidence-based dementia treatment to people who are still living at home and in the community to extend and improve time at home for people living with dementia and their family care partners.
Great, thank you, Jill. John Kantke, please.
Yeah, thank you. I'm John Kantke. I'm an attorney at Estate and Elder Law Services in Northeast Minneapolis. We're a nonprofit law firm. We're owned by Volunteers of America, Minnesota, and Wisconsin. And then I'm an adjunct professor at the St. Thomas School of Law. I teach the Elder Law Clinic there, and a lot of the work at both Estate and Elder Law Services and at the Elder Law Clinic at St. Thomas is about capacity, about legal options and advising clients when a loved one is suffering from some form of diminished capacity.
Thank you, John. And Dr. Pacala, please.
Good afternoon, everyone. My name is Jim Pacala. I am a family physician and a geriatrician. I am the head of the Department of Family Medicine and Community Health at the medical school, and one of the colleagues of Dr. Gogler in the Minnesota Northstar Geriatrics Workforce Enhancement Program.
Thank you. Dr. Pacala is being humble. He's the director of it. So we're glad to have you today too. Okay, well, everyone, how we're going to do it is this way. We're going to start by addressing one question that came up more often than any. I think many of you probably can guess at what that is. After that, and so each of us are going to reflect on that particular question. Then I ask each of the panelists to pick amongst the many questions that have been submitted to us prior to the event for them to address directly. And after that, I will then moderate the remainder of the session to address questions that you might be submitting during the event or to address questions that, again, have already been submitted. Once again, I'd like to emphasize, please use the Q&A function at the bottom of your Zoom screen to submit any questions. And I may try to answer them myself vis-a-vis typing if needed. So what was that one question that so many of you asked? As you can imagine, it is connected to recent events, and that recent event is the FDA's provisional approval of a new drug for people living with Alzheimer's and Alzheimer's disease-related dementia called Aduhelm. And so here were some of the example questions that came through. For people with mid to possibly late-stage Alzheimer's who are still very independent, is the drug Aduhelm an option? Surely there must be newer, more effective medications for dementia. All we have had prescribed is Aricept. What are the panels or panel members' thoughts about the new drug just approved for Alzheimer's? Again, our care providers share that they aren't offering the newly approved treatment Aduhelm. I realize that there's some controversy and risk, but how can I find a provider that is prescribing it to see if my loved one would be a good candidate? These are just a few of the questions related to the new drug. And I think we felt that it was important up front to address some of these questions. So I'm going to turn to each of our panelists to hear their thoughts. And Jill, I'm going to start with you. What are your thoughts about the new drug and its provisional approval?
So, like the attendees of this webinar, our clients and families are asking the very same question. So something that we're telling and sharing with our families is that it's not readily available yet. It will take some time before insurance and Medicare regulations are worked out, and the assessment and monitoring procedures because of some significant risk factors. So it's not a treatment option that will be available for everyone, and it's not a cure for dementia. So we're urging caution. And if you wouldn't mind, Joe, I'll share my screen and just put our angle on it. I know that our pharmacist will probably have a much better answer, but can you see my screen?
Yeah, it looks like.
Oh, good. So we like to tell families that no medications are the magic solution. Medication management is one piece of the puzzle, but there are non-drug dementia interventions that we know to be effective and beneficial. It's not the easy answer that taking a pill is, and we'd all prefer an easy answer, but there's been just as much research behind non-drug treatment options that really reduce those difficult dementia behaviors and symptoms that make life difficult for everyone, the person living with the condition and also their families. So there's been a lot of research to show that non-drug treatments improve quality of life, not only for people living with dementia, but also for their families. So that's the sort of treatments that we deliver here in our clinic, based on, and I just think it's important for people to know that there are non-drug treatment options available. We deliver 3 called COPE, Care of Persons with Dementia in Their Environments, New Ways for Better Days, and Skills to Care. These are interventions that we deliver through occupational therapists and social workers, and we see excellent results similar to those found in clinical trials. So we would like to see everybody have access to both drug and non-drug treatments. So we encourage everybody to look in their communities for some of these treatment programs that aren't only medication-based, because it really does take a comprehensive approach to manage dementia progression at home.
Thank you so much, Jill. That was great. Dr. Gustafson, do you have any thoughts about the Aduhelm drug?
Yeah, thank you. I agree with everything that Jill said. Again, I'm not a prescriber. One thing that, I'm glad people are asking questions and inquiring about this. I think there needs to be, as we kind of continue to move forward, a shared decision-making process where patients and family members and providers are working together to understand the information currently available, making that understandable in a culturally meaningful way, and then making a decision that's aligned with what matters most to that patient. So I think these are all steps kind of going forward to think about, and that people should still be asking questions and inviting that curiosity about what's happening there.
Great, thank you, Allison. Dr. Pacala, what are your thoughts?
Well, first of all, I'll say that I have rarely seen the approval of a drug create more controversy in my career than the last few weeks of this FDA approval. That's the first thing. The second thing I'll say is that having taken care of patients with Alzheimer's disease for the past 30 years, I desperately want a drug that will work and will work meaningfully. The third thing I'll say is that currently the drugs that we have to offer are at best as effective as the treatments that Jill described, the behavioral treatments. So it's important to understand that what we have right now in terms of drug therapy is not very helpful. The fourth thing I'll say is that the tantalizing thing about aducanumab, Aduhelm, that the tantalizing aspect of it is that it seeks to attack the actual cellular process that creates Alzheimer's, and what that ends up in is the buildup of these amyloid plaques. Amyloid is a type of protein in the brain, and what this drug does is it binds to these proteins and gets rid of them. So you end up thinking, wow, that could actually arrest the disease and stop it. As tantalizing as that sounds and as hopeful as that is, the performance does not match our hopes. And the single trial that this approval is based on was really a disappointing trial. There have been trials of other monoclonal antibodies similar to this agent that have been negative trials that have not worked. So unfortunately, the medication is really controversial in that it doesn't appear to be, at least from this one trial, the magic drug that is going to actually arrest the disease process itself. On top of that, and I'm sorry for taking up so much time, Joe, but on top of this is something we have to think about as prescribers. But on top of that, it also has a problematic safety profile. So as you've probably heard, about 40% of the patients who got this in trials had noticeable swelling or microhemorrhages, small amounts of bleeding in their brains, 40% of them. 20% of the patients developed headache on the medication. 10% of the patients had the swelling or the bleeding or side effects that either limited their ability to achieve a maximum dose or they had to stop the drug. So this is not a very well tolerated agent. And it is for what was in one arm of this single trial, a very, very modestly observed clinical benefit. The last thing I'll talk about is cost, and some of the others might want to address the costs as well. But you'll read in the paper about the cost being $56,000 a year. That sounds like a lot of money, but that's not even close to the cost of this treatment, because that's just for the drug itself. To actually get through a single year of treatment, you're also going to need to have one PET scan or a spinal tap, which is expensive and not paid for by insurance, at least not planning, no insurance yet, currently pays for that. Plus 3 brain MRI scans, 3 brain MRI scans through the first year. So those are added costs, and they're very significant costs. And then there's all the costs of taking care of those side effects that I mentioned. So it's very, very controversial. It's going to be, frankly, a very, very challenging agent for doctors and other providers to prescribe. And we're going to have to figure out how to set up systems to properly give access to this for patients and to be able to make sure that they're safe when they're taking it.
Thank you so much, Jim. That was great. Really appreciate it. Dr. Busker, I'd love to hear your thoughts.
Thanks. With regards to Aduhelm, and I know the question came up that you read in the beginning there, as far as, can somebody with moderate to more severe late stage Alzheimer's, would it be an appropriate option for them? I think too, just to add to what Dr. Birkeland just said, is that the studies looked at patients with mild cognitive impairment and very early stages of dementia, so mild dementia. So moderate to severe disease was excluded. The age range was 50 to 85. So I don't think it wouldn't be recommended, for patients with more moderate to severe disease, or even over 85 years old as well. So I think that's important to keep in mind too. And as Dr. Birkeland mentioned, it's just very unclear what, this beta amyloid plaques, we see that reduced, but how does that really translate into clinical significance? So I think that's all I have to add to what's been said already. Agree 100%, and coming from a pharmacist, the non-pharmacological, interventions are so important. And we'll probably get to that a little bit later as well, it's my guess.
That's great, Amy. Thank you. John, I don't know if you wanted to share anything from a legal perspective. That's kind of a little different take on it, I think. I'm not sure if you have any insights or thoughts.
Yeah, I guess, my background's not medical, but as far as advising clients, just basic, incapacity planning, I think, comes into play here as well, making sure everybody has the healthcare directive. They've thought about treatment options. They've communicated their wishes about treatment options, and making sure that, when opportunities like this become available, have we thought about them? If there is a treatment, but there is significant cost, is that something you want to pursue? What is the trade-off? Are you, for most of my clients, they wouldn't be able to afford a treatment like this without, completely draining their, resources, or almost draining their resources. And is that worth it? Is that a trade? Talking through with clients, how do you balance money versus, potential cure, and how do you rank those things? But making sure you've thought about these things in advance, and that this appears to be, again, for someone with moderate symptoms, and hopefully this is a person that can contribute to that conversation, saying, yes, I understand the risks, I understand the costs, this is a treatment I want. But if treatments become available in the future where the person can't contribute to the conversation, they're not aware, they're not able to weigh the risks and the benefits, that they have a decision maker put in place ahead of time who is familiar with this person's wishes and this person's value system, that they can make a decision on future treatment opportunities in the future.
Thank you so much for that, John. Really appreciate it. Robin Fraser, what are some of your thoughts?
Yeah, thank you, Joe. As I think about it, I agree with those things that have already been said, but I think of it in with the equity lens of accessibility of this drug. And I work on the front line with people that are still struggling to get resources for a diagnosis. And so when you look at the cost of the drug, as Dr. Birkeland covered, and the high level of care that would be involved with this, I think that, this is going to apply to a certain segment of the population, but I don't see it applying for a large portion of the people due to the accessibility and the cost. And until this is covered by Medicare or insurance, it's just not going to be a viable options for a lot of people in our diverse and underserved communities.
Thank you so much, Robin. Really appreciate that. And then Dr. Birkeland, Robin Birkeland. Or yes, Robin Birkeland, thank you. I get it mixed up sometimes.
There's too many of us. Yeah, honestly, I think from dealing with family members, and they've been calling and kind of asking about this drug for a while now, ever since it was announced that it had been approved. And I think the things that stick out to me is that this is, when you typically get the diagnosis of Alzheimer's, there's not really like, and here's your treatment plan, and here's your hope package. You don't get that. You just get, here's the diagnosis, and you can do things with your life and you can have quality of life, but there's no hope really given that is like that they can take with them and figure out what they're going to do. And now we have this drug that, like as Dr. Birkeland said, has some hope, or like offers that hope. And it stuck out to me so much that family members, instead of being like, yes, this is awesome, have been calling saying, I'm having some concerns about even thinking about this. I really am worried that it might not be the best idea for my family member. What do you think? It's not like people are just taking this and running with it. People are asking good questions that are really, like in a situation where they could just be like, yes, something has finally happened. We haven't had a new drug in so long, and the drugs we have are terrible. And this is great. Everyone's looking at it with a really good critical lens to try to figure out, hey, is this right for my family? Is this right for my person with memory loss? So I think that really speaks volumes to how well people are kind of thinking about this critically and thoughtfully. I do want to say too that you may have received this as a part of our caregiver registry, but if you're not a part of our caregiver registry, we did send out a frequently asked questions guide that we had put together from information from Emory and UCLA. That has a lot of good, and we try to update it as soon as we get new information to make it new. So we can send that out if you need those as well, because I think that's really some good information there too. And then the other thing I just want to hammer home is the side effects, and to consider, if you're going to consider the drug, to think about those side effects, to think about what those scans will be like, what the spinal tap will be like, and if that's something that you think your person will want to, how that will affect their quality of life. And it may be worth it, absolutely may be worth it, but just kind of to make sure you consider those things as well.
Great, thank you, Robin. I'll kind of wrap this up, and I'm going to wrap this up based on some of the questions that are coming through the Q&A panels here. And it's really interesting questions. Some of these are pretty provocative questions. When I think of this whole process, I'm going to be, I'm going to be transparent. I collaborate closely with the Alzheimer's Association, both at the national level and then the local level too. I have a lot of respect for some of the other advocacy organizations involved, like Us Against Alzheimer's, and all the things that they've been able to accomplish. I think when one steps back in the context of all this, really since the National Alzheimer's Project Act was signed into law in 2011, groups like the Alzheimer's Association and Us Against Alzheimer's have been at the forefront for advocating for greater federal investment in the science of dementia, studying dementia, developing therapies, and also with an increased focus on non-pharmacological approaches. How can we improve care for people living with dementia and their caregivers as well? So it's a challenging situation for me in that I have great respect for these organizations, but I have to disagree with, some of maybe their positioning on this. I think some of the questions in the Q&A were about, some of the statements coming out of the Alzheimer's Association related to the support of the drug and et cetera. What I've been doing actually is I've been compiling a lot of the media reports, the actual original FDA reports I've been reviewing, really just trying to compile as much as I can, learn about Aduhelm, to also share with families and healthcare professionals like Dr. Birkeland had mentioned. And I have to be honest, I've been hard pressed to find many voices that I respect in the scientific community that have been in favor of this decision. And this is just an objective observation. So why this happened, I think part of it was probably, again, there was a real emphasis that we've made all of this investment in the past 10 years. This might be an opportunity to show some payoff for that investment. I don't know. But that's still, even with my desire to give hope to families, given we do a lot of community engagement, this event is an example of that community engagement, of wanting to give families and people living with dementia hope. at the same time, you know, you can't dismiss the research and the findings. And you know, one of the things, and Robin Fraser talked about this a little, and it's also on this tip sheet that Dr. Birkeland had mentioned, and which we'll share with you as well if you haven't gotten it yet. One of the things that was really striking to me is the FDA approval, provisional approval, was based on 2 studies that included overall around 3,500 people. In that sample, less than 0.1% were Black. And there was 1 Native American, Alaska Native across both studies who enrolled. And so basing an FDA approval on that kind of sample raises major questions to me about representation, inclusion. I mean, and there are many other issues here. We don't have to go through the entire laundry list. Those are easy to find if you're doing any kind of research on it. Again, this is a very unprecedented decision. I think everyone on the panel would agree. I've never seen anything like this. I've never seen 3 of the experts on the FDA scientific advisory panel quit because of it. So it's problematic, and it'll remain to be seen, quite frankly, whether this drug will have major impact on care overall. Dr. Birkeland mentioned about the cost implications. I've actually seen some reports out of the Kaiser Foundation. They ran some economic models of this, and essentially, if Medicare covered this, it would cause significant strain to the Medicare budget. So if anything, if this drug is rolled out and administered, it'll probably be in a limited fashion. I have heard of healthcare systems actually deciding not to offer this treatment, in part because of the cost implication, and then also questions again about its overall efficacy or effectiveness. So in the long run, I'm not sure how it remains to be seen how this is actually going to impact overall care in terms of how it's delivered in the context of dementia. I mean, those were my thoughts. So, all right. Well, again, that was a great way to start off our panel. For the next part of our conversation here, we wanted to we wanted to give an opportunity for each of the panelists to pick one of the questions that were submitted prior to the panel and give them an opportunity to answer it. And then if the other panelists wish to chime in, they can. So I'm actually going to start with Robin Birkeland. Dr. Birkeland, if you had a slide to share, you could please do so and share with us your that you addressed.
Absolutely. So my question was, if someone with dementia begins to tell stories you know did not happen, should you go along with them or not? And the short answer is you go along with them. The more informative long answer is that this is very, very common in dementia. I'm sure you've all experienced this. And you know, it may happen because someone just has gaps in their memories and they're trying to fill it in. That feels better to have a full story to tell. It may be that they're just remembering it incorrectly. It may be that it's an expression of some emotions they're feeling at the time. And so it's just, you know, not related to an actual memory, but more this emotional expression. And there's probably 100 other reasons why it happens, but regardless of why it happens, rule of thumb, don't argue, agree, don't correct. And, you know, that can be a lot easier in certain situations. You know, if your mom says that you went to school in Georgia and you didn't, big deal. If your mom says your dad's cheating on her, if your husband says you're cheating on him, that's a lot harder to just be like, oh yeah, it's okay, I'm not going to argue with that. I mean, you want to defend your honor. You want to like correct them and make them see that that's not right. And so there are times where you can let it go because, you know, you're working with a fully functional brain. They are not, and arguing with them is not going to change anything. The part of their brain that's responsible for rationalizing and thinking on second thought and kind of figuring it all out logically, it's under attack by disease. So you're not going to be able to make a change. And I'm sure you've had that experience too, where no, that's not it. And it doesn't get you anywhere. And it just escalates and escalates and escalates. And now you're frustrated, they're frustrated, and nothing has changed. So let it go is what we would absolutely recommend. But as I said, sometimes it's harder than others to do that when it's, you know, it feels more of a, you know, an emotionally weighty issue. You don't want to just let it go. So our do nots, do not correct, do not argue. try not to take it personally, because it's not meant personally. It's not something that they've contrived to attack you. It's just, you know, something that's coming up. So really try not to take it personally, as hard as that might be. What you can do is try to stay calm. Try to reassure them, really talk to, you know, like that emotion they're experiencing, and you know, like, don't just shut it down and say that, yeah, that's wrong that you're feeling that way. Like, show that you care about how they're feeling. You know, okay. Oh, Mom, I hate that you're feeling that way. I'm so sorry that that's how you're feeling. Like, you know, speak to that. But more than that, try to look for the reason why they may be saying what they're saying. And this works for repetitive questions as well. Look for what it is that is making them feel that way. If you can come up with like the why they keep asking where Dad is, you could possibly make them feel better. If you can come up with, okay, here's the reason for this, then you can think of different ways to cheer them up. You know, if they are, you know, saying that Dad is cheating on them, and, you know, poor Dad died 10 years ago, and that's not at all what's happening here. She may just be missing him. And so you can reminisce with her and talk about Dad. Oh, I was thinking of this time when, and kind of just talk about him. And that might make her feel better and relieve that feeling of missing him. You could also try to distract, you know, let's take a walk. Let's look at pictures. Let's listen to some music. Music and pictures go over really well. Let's call your sister and talk to her. Like, whatever it is that you can do to kind of distract, that can be very beneficial as well. And sometimes I just want to say, you may need to take a break and give yourself permission to take a break, because it's hard. And you may be like, I've heard this question 500 times. I've heard her attack, you know, like, feels like she's attacking me on this issue. I need, you know, like, I just need something. And so give yourself permission to take a break, because it's only going to escalate more and more if you stay in it. So, you know, hey, I'm going to grab a glass of water. Do you want one? Or I'm going to go to the bathroom. I'll be right back. It doesn't have to be a long break. I know, like, some situations you don't want to leave for too long, but just, you know, just that little bit of time will help provide a little buffer, and it can make it much better when you return to the conversation. And, you know, they may have forgotten by the time you get back, but at least, if not that, at least the emotions will be kind of a little bit simmered and it won't be as bad. And I wanted to quickly too talk about a couple of other things that are related. Paranoia and hallucinations. With paranoia, it's another thing it's very common with Alzheimer's. And part of that is there is positive reinforcement for it happening, because if Dad says, I put my keys on this table, and then he picks them up and walks away with them and puts them somewhere else, but doesn't remember that, when he goes back to the table and the keys aren't there, somebody must have taken them. Somebody stole them, somebody's pranking him, somebody's doing something here. And if you think about it, for us, it'd be the same. If we put our phone somewhere and then we came back and it wasn't there, you know, who took it? Like, we didn't move it. And so that's what's happening. And so, like, it's just reinforced every time because I put it there and it's not there. So you will probably end up having to deal with that sometimes too, where, you know, you're like, no, honey, I didn't move that, you know, like that. They're just like, we'll find it together. Don't argue, just we'll find it together. Let's look. And, you know, and if you find it in the sock drawer, he's like, I would never have put it in the sock drawer. That's, you know, maybe at the time he was thinking it was soft in there and be nice. Who knows, but you just kind of go, oh, I don't know how it got there either. Just, you know, just kind of go with it. And hallucinations too, I don't have time to really get into how to deal with those, but Teepa Snow has some great videos that you could watch, but I just wanted to make sure I touched on it, because that too was another thing where a visual hallucination where you're seeing something that is not there, it feels real. It is real to them. And sometimes those hallucinations are very emotionally based. So it might be a child that needs help and they can't get to them and they can't help them, or they need to help them and they can't. That is real. So also don't dismiss that and don't try to like, oh no, that wasn't that. Like, again, stay calm and kind of speak to the emotion, reassure them, but don't argue with them that it's not happening, because that'll just invalidate how they're feeling.
This is great, Dr. Birkeland. Thank you so much for sharing. I know the questions have
You're
come.
welcome.
Yeah, this has been great. I know there's been a lot of questions about whether we will be sharing these slides, and we definitely will be, along with the recording of this event. So again, we're going to be sharing all of this with you. Thanks again, Robin.
Absolutely.
Thank you. Yes. And so I wanted to turn to Robin Fraser. to hear about the question and topic that she addressed in, again, in response to the questions that came through.
Okay, thank you, Joe. The question that we are going to address is, there was a person that said, I have many family and friends that have said that they will help me with caregiving. But they said, what's happening is I am getting really tired that I have to reach out and initiate and schedule things with our family and friends, that things that they should be doing. What tips, tricks, and advice do you have to get those well-meaning people to step in and be there without me having to ask? And so with regard to this question, one thing I think can be helpful is to reflect on what might be an underlying contributor to why people aren't proactively reaching out. And so one thing that can happen is everybody assumes that the caregiver and family have such a vast network. They're assuming that everyone else is helping. You know, they'll call me if they need my help because they've got this vast group of people. So they're not calling, they don't need help, but everybody's making that assumption. So in reality, no one's calling because we all think someone else has picking up that role. Another contributing concern can be that people have various levels of knowledge and comfort on Alzheimer's and dementia, and we know that that can vary widely across racial and ethnic groups. And so for some people, you know, if they have not had education about the disease, they may be a little bit unsure of how they can help or what they might be asked to do. And then, you know, we never know, I say, what journeys others are on. And so sometimes family and friends, you know, they have personal issues, finance, work, health challenges that they may not be sharing, but it limits their ability to help. And then the last thing that can contribute to this gap is that whatever family relationships and friendships and dynamics existed before the person was diagnosed with Alzheimer's or dementia, those are still there for people. And so that past can carry over to the current. So if your sister's never been there to help with mom the entire life and you've always been that person, you're probably going to be that person. It doesn't mean that their role is going to change. But in terms of the caregiver and what they asked in terms of what can be helpful, one of the things is I know that a lot of caregivers, when they're feeling overwhelmed and exhausted, it's not usually during what I'll call normal business hours. And so one of the resources that I share is the Alzheimer's Association's 24-hour helpline. So this is a resource available day and night, around the clock, 365 days of the year. That number is 1-800-272-3900, and they also have alz.org. And so what a caregiver can avail themselves of at no cost, so there's no charges for the service, is they can talk to a dementia expert, and often it's someone with master level clinician, and they can get information on how do they get their family engaged, information on caregiving, and also resources that are available. So I would definitely recommend using the Alzheimer's Association number. I work with several different church caregiver groups, and all of them have given a thumbs up that they receive the support and help that they need. The other piece of this is really figuring out how to reach out and get help. And so when you say I need help, everybody kind of has that fear of, it's like if somebody says, are you available Saturday? And you're like, I don't know if I'm available or not. What are they going to ask me to do? So that can be the situation for a caregiver. And so one of the things I would recommend with the caregiver is they take a look at what kind of support would be most valuable for them, and just make a list of those 3 to 5 things. And as you think about those items, think about something that might be a one-time project, or something that might be seasonal versus something monthly versus something weekly. And then if you can put that together and maybe have a friend help you do outreach, whether it's calling or emails or actually sending a letter, then people can see the different ways that they can support you and your loved one and your family. And they'll know, what they are signing up for and what would be required. The other suggestions, just to wrap up, that I would share is the value of being in a support group. The support groups, there's not going to be a new scenario. And so when you're with people that are on a similar journey, they're able to share with you what they have found that works. And every person is different and every journey is different. But by being in a support group, you can learn from others and share your experiences. And then 2 other suggestions. One is take a look at resources in your local community. As we know, we're an age-friendly university at UMN. There are cities like Brooklyn Park that are doing age-friendly initiatives. So they want to take a look at how do all of their residents live well and remain in the community. And the other suggestion is taking a look at county services and the area agencies on aging. And so those are regional and local resources that are available because your loved one may qualify for having some home care services. It might be adult day, those types of programs. And then the final one is reaching out to your faith community, whether that's the mosque, the temple, the church. Many of the faith communities, they often have nurses. They have health and wellness groups, because if you think about it, their population is aging and they want to be relevant and they want to support people. So whether it's joining a church caregiver support group or receiving that pastoral care for your spiritual wellness, those are some of the places where a caregiver can go and get that vital support, because this is a very long, hard journey. And to me, there's no one magical thing. It's really putting together several things like a puzzle that give you the support you need. Thank you, Joe.
Oh, that was great, Robin. Thank you so much for your wisdom and insights. We so appreciate that. All right, next, let's turn to John Kantke, our lawyer, legal expert. Lots of questions came in related to legal issues, and so glad to have John on the panel to help address some of those.
Yeah, thank you, Joe. Are you able to see my screen? I'm attempting to share.
Yeah, looks great, John.
Awesome. Yeah, hearing everybody share today, I mean, this is an amazing group of people and a lot of great information. I am just going to touch on a little slice here on the intersection of diminished capacity dementia with the law. Some of this might be very basic, a review, but really this centers around, if we look at incapacity as a legal issue, how do we address it? And the first concern is always trying to get people through this issue of, I have a diagnosis and all of a sudden I don't have any options. And from a legal perspective, as an attorney, there are still options on the table. I am not limited by a medical diagnosis as far as what I can do with my own client when we're meeting for other purposes. So the questions that I'm trying to address today kind of illustrate two different times where this issue of incapacity could come up. The first question is someone would love to hear more about how capacity can vary by subject, by time of day, and how we can meet people where they're at. I'm going to take that from a legal perspective, but certainly other people on the panel could address that from other perspectives as well. The second question is, how is it determined when someone with a power of attorney can make decisions? And so I'm viewing this as two different times that we're analyzing capacity. One is if they're coming to meet with me and I'm an attorney and I'm looking at how do I address this issue? Can we sign a healthcare directive? Can we sign a power of attorney? I am trying to assess capacity at that time when we are signing the legal document. The second question here is addressing later, saying that there are documents in place and that this document has a springing power to it, a power that comes to life in the future. How do you know when that power gets transferred? When is it my time as the agent for someone to step in and make the decisions? I'm going to focus more on the first one because that's the easier question. The second one is very hard. The second one often has more to do with the person receiving the document. If it's a healthcare directive at the doctor's office, if it's a power of attorney at the bank, if the person receiving the document has concerns about the principal, the original decision maker's abilities, they will often look to the agent. And on the attorney side, I'm not involved with that. I'm not involved in when a doctor says, I'm not comfortable with this person making the decision for himself or herself, I'm going to go to the healthcare agent. That's on the medical side. I am involved with the process of establishing those documents though. And so when I talk about incapacity planning, that has become its own area of law that we have to plan for. And that's been one of the biggest changes, I think, in the law over the last 30 years, is you didn't used to have to plan for incapacity. It was just family making decisions. Family relationships were assumed to be the people that you wanted to make decisions for you. Now, because of HIPAA and other privacy rules and regulations, we are all siloed from an information perspective. And my marriage certificate does not give my wife any authority to bypass the HIPAA rules to access my information. I have to have a healthcare directive that waives the HIPAA restrictions and allows my wife to be my decision maker. So marriage, parent-child, siblings, any of these relationships are not enough to waive the HIPAA privacy rules. And those rules were put in place with good reason. But now we need to plan for them, and we need to go an extra step and create waivers to those. So it could be a power of attorney, a healthcare directive, a simple release of information. It could be a trust to manage assets. There are different ways to plan ahead for incapacity. But what I really want to focus on here is that capacity is situational. And that's the first question that came up here. And when I'm meeting with a client, I have to ask what their capacity is in a specific context. It's not a global assessment. There's not some score that follows them around from the doctor's office to the attorney's office to the bank. I have to understand, do they have the capacity to do what? And in my case, it's, do they have the capacity to sign this healthcare directive or sign this power of attorney document? And that's a very specific analysis. And it's an analysis as an attorney that I get to make independently. I'm not bound by a medical opinion or some other opinion of a therapist or something else. And so from me, what I'm looking at is, number one, diagnosis does not equal incapacity. So just saying someone has dementia, that does not mean that they are incapacitated, because capacity is analyzed specifically. So these two things can coexist. We can have a diagnosis of dementia and we can still have capacity to sign a healthcare directive. Do they know what they're signing in the moment is another piece of this. they are not required to remember what they signed later. It does not invalidate the document if within the next hour they forget what they signed. As long as when I'm meeting with them, they can articulate what they're signing at a very basic level, I'm comfortable that they know what they're doing. And I'm considering the context too. I'm considering, are the questions that I'm asking, are they being answered consistently? And are they being asked appropriately? And the reason this is important is oftentimes clients, when they have a diagnosis of dementia, they are told that you need to become, someone needs to become guardian for this person. And guardian is a court process. And in Minnesota, the terminology is very specific. We have guardianship and we have conservatorship. So on this slide, I'm trying to illustrate the two different parts that we're planning for. Number one, financial, number two, medical. And then are we dealing with incapacity before it happens or after it happens? And that's never a clear line. That's always a blurry line. Time of day, day of the week, etc. I might, when I'm meeting with clients, I'm often asking them or their family members, when is the right time to meet with my client? Is it in the morning? Is it later in the week? Is it earlier in the week? Because I want to meet them where they're at and try to find where they are at their best, not at their worst. But the terminology in Minnesota, if I'm going to court and doing a guardianship or conservatorship, that is unnecessary if I can do something less restrictive, such as power of attorney healthcare directive. And we have an idea now of supported decision-making as well, trying to make decisions with someone, even if they have diminished capacity. What are their wishes? What do we know about them? What can they communicate? And let's keep them in the loop. Let's make decisions with them instead of for them. So this next slide here, from a legal perspective, why we're trying to avoid guardianship and conservatorship is because it is drastic. It is a complete removal of rights from someone, and it's a reassignment of rights to someone else. And in America, we love our rights. We have so many rights and we know our rights. And yet in guardianship context, we, in an unknowing way, in a well-intentioned way, but yet a cavalier way, we are taking rights away from people. And even though someone has dementia, we should not be taking rights away from someone unless it is absolutely necessary. With power of attorney healthcare directive, it's a simple duplication of rights. It's not a removal. And so that's always my preference. That's always my first choice. And the statute requires it. The statute requires me to try to execute less restrictive alternatives before going through guardianship and conservatorship. The last two slides here are just extra resources if you're interested. I'm an attorney, but we have a very active and robust social work team at Volunteers of America, and we team up once a month to do this, what's Incapacity, but we call it the Guardianship Information Clinic, where people can drop in on a video call and ask about these questions. Do I need guardianship? Can I do something different? And there's also the Guardianship Information Line that Volunteers of America offers as well. People that are wondering, how do I help someone? Again, the issue is incapacity. What do I do? What are my options? I'm overwhelmed. It's a free call, and they'll talk you through your options as well. And that's the end of my slides, Joe.
Thank you, John. That was just great. Really appreciate it. I'm going to turn to Dr. Birkeland next. Jim, love to hear the question that you're addressing and some of your insights.
Thank you, Joe. My question is, what are the different kinds of dementia and what treatments, if any, are available for each? So what I'm going to do first is describe what dementia actually is and how it's diagnosed. And then I'm going to go through the four most common types of dementia, and I'll show a slide for that. But first of all, dementia is a progressive and sustained cognitive loss that interferes with functioning. So let me just break down that definition. Progressive means that it gets worse over time. Sustained means that it isn't temporary. So for example, if you're acutely intoxicated, you have a loss of your cognitive abilities and it interferes with your functioning, but it is not sustained. So sustained means months to years, and that distinguishes it from acute intoxication or delirium, which usually lasts hours to days and perhaps weeks. So it's something that occurs over months to years, and it interferes with your functioning. You don't function as at a level in which you previously functioned, and that's what distinguishes it from developmental disabilities. So taking that definition of dementia, then there are, which is a generic definition, there are actually 4 of the most common types of dementia that are shown. Let's see here. Can I do this? There we go. Is that good?
Good. Yeah, looks good.
All right, awesome. Learned something of my Zoom capabilities over the past year. Okay, so the 4 most common types of dementia are along the left-hand side, and I'll just briefly outline each. So the first one is Alzheimer's disease, which is responsible in the middle column for about 60 to 80% of all cases of dementia. So it is by far the most common. And as I'm sure the audience knows, is that memory is a very prominent component of Alzheimer's disease. And only late in the disease does a distinct change in personality often come. In other words, early on and in the middle stages of Alzheimer's disease, it's still the same person that you used to know. They can't remember things as well and they get confused, but it's still essentially that same person. And later on, you may see hallucinations and delusions, as Dr. Birkeland was talking about. The second most common type of dementia is vascular dementia, and this is can be thought of as very tiny subclinical strokes that occur that interfere with the blood flow to the brain, and as the blood flow in very small parts of the brain is obstructed, that creates neuron brain cell death. And that occurs over a long period of time. So vascular dementia is caused by vascular risk factors. Cholesterol, hypertension is now a recognized risk factor for the development of dementia. And so these are folks who have vascular disease and can develop a vascular dementia. Lewy body dementia is the buildup of a certain type of protein called alpha-synuclein in the brain, and it creates this structure that you can see in the brains of these people called Lewy bodies. Lewy body does affect memory, but it's usually a slightly more rapid course than Alzheimer's and vascular, which takes years, 8, 10, 12 years to develop. What you'll see in personality is a slowness to the person, and they often have features of Parkinson's disease. So they'll have a staring expression, they'll move very slowly, might have a tremor, and so forth. One of the things that clinicians look for in trying to diagnose Lewy body is an earlier than expected appearance of hallucinations, and usually the hallucinations are fairly vivid. So if you see somebody with mild or even moderate cognitive impairment, but they have very vivid hallucinations, you're more likely to look and think of a Lewy body dementia rather than an Alzheimer's or a vascular dementia. Now, before I get to the last category, you'll notice that there's a lot of overlap among those 3 common types. And this is one of the difficult aspects of diagnosing dementia accurately. The best way to diagnose Alzheimer's disease is with a brain biopsy, drilling into your skull, taking out a piece of brain and looking at it under the microscope. We don't do that. So we have to be able to diagnose dementias and try to figure out the cause of the dementia from the clinical characteristics and the behavior of the patient. And there are tools that we use to do that, but they are not precise. And so there's always a bit of uncertainty in this. And one of the things that I think the audience would benefit from is when they're dealing with their doctors who are treating a dementia, to say, how confident are you that this is Alzheimer's, or how confident are you that this is Lewy body? And really trying to get them to come clean, as it were. I have patients who I'm very, very confident have Alzheimer's disease. They have really the time course and the memory deficit and the language difficulties that you expect in Alzheimer's disease, and they don't have any vascular risk factors. They got normal blood pressure, low cholesterol, they don't smoke, stuff like that, and no movement disorders. I mean, not too many other illnesses that we know of. In fact, none other would really create that constellation of symptoms. So in a patient like that, I would be comfortable saying, you know what, I'm really confident here that this patient has Alzheimer's disease. Folks, that's a rarity. That doesn't happen most often. And most often the world in medicine is grayer than that. And that you have patients with features of Alzheimer's disease, but they may have a couple of vascular risk factors, or they've had a heart attack in the past. So you know that they have vascular disease. And so you're trying to put this together and decide, you know, what is the cause. So so that there is definitely a bit of uncertainty there. The last thing I'll say on these first three is that you'll notice that if you add up the percentages, they'll add up to greater than 100%. And that's because there are a lot of people who have a mixed dementia, who have more than one type. And so I'm sure that there are many patients in my practice who have Alzheimer's disease and a component of vascular dementia at the same time. So it's not just that there's going to be one cause. Sometimes there's a couple of different etiologies. The last type is frontotemporal dementia, or FTD. That is a disease that used to be called Pick's disease. It is fortunately, if there can be some fortune in the world of dementia, it's fortunately pretty rare. It is a disease that preferentially attacks the frontal lobe and the temporal lobes of the brain. And what those do in terms of cognitive and brain function really control emotions and how you relate to other people. And so in frontotemporal dementia, you don't have early memory loss. It's one of the biggest distinguishing features. You have a decline in your ability to function, but it is not because you're forgetting things. It's because you're making bad decisions. It's because you're reacting strangely to situations that you've reacted in a conventional way most of your life. So one of the things that can tip people off to frontotemporal dementia is that the person's personality is actually changing. They're turning into a different person. They don't act like they used to. So a person who used to be open and gregarious might become nervous and withdrawn and fearful of other people early on without memory deficits. That should cue you into a possible FTD diagnosis. Now, in terms of treatments for each of these, for Alzheimer's disease, the main drug treatment, we've already talked about some of the behavioral therapies, which are probably the most effective therapies we have. There are drug therapies, and for Alzheimer's disease, it focuses in on neurotransmitters. So neurotransmitters are the chemicals that connect brain cells together. And when you're having brain cells that die from Alzheimer's disease or one of these other causes, then you're having more difficulty making those connections between the existing brain cells. And so what the drug therapies for Alzheimer's disease do is they actually inhibit enzymes that break down those neurotransmitter those neurotransmitter chemicals. So one of the most common in the brain is called acetylcholine. And acetylcholine is a very common neurotransmitter, and the drug Aricept, or donepezil, which is a common drug that's prescribed in Alzheimer's disease, inhibits the enzyme that breaks down acetylcholine. So what it does is it increases the relative amounts of acetylcholine in the brain and helps to connect those cells together. Turns out that the part of the brain that has one of the highest percentage of cells that use acetylcholine as a neurotransmitter is the part that controls short-term memory. And so that's the connection where that short-term memory loss is from deficits of acetylcholine. So the drug helps to restore acetylcholine and connect what cells are functioning there and can help to preserve memory. Now, some of these neurotransmitter drugs like donepezil, like memantine or Namenda, that work on neurotransmitters have also been shown in studies to have some effectiveness in vascular dementia. So in my patients, it'll be common for me to prescribe an enzyme inhibitor in patients with AD and also who I think may have vascular illness. Now, vascular dementia, you want to control risk factors. So controlling hypertension, cholesterol, getting a patient off smoking, those sorts of things are treatments that we apply for vascular dementia. Lewy body dementia, there's a growing but still modest body of research that shows that those enzyme inhibitor therapies can be used as well and can be somewhat helpful. Very common in Lewy body dementia, there will be movement disorders or Parkinsonism. So drugs that we use to treat Parkinson disease will also frequently be prescribed in patients with Lewy body dementia. Frontotemporal dementia, or FTD, is a very, very difficult situation because we have not identified any drugs that are effective in mitigating symptoms or improving things. So that is a very, very challenging diagnosis and difficult to navigate, not just for patients, but for doctors as well. Last thing I'll say, and I commented this in my opening comments, is that you'll notice that the drugs that we have don't attack the actual root cause of any of these conditions. What they do is they help to maximize what brain function is still there rather than attacking the root cause. And that is something that is just incredibly frustratingly difficult and elusive to our researchers. We understand a lot about the chemical changes that take place in cells. We can describe what happens with proteins that build up in patients' brains, with Alzheimer's disease, with tau neurofibrillary tangles and beta amyloid plaques. But actually figuring out a drug that will prevent that from happening in the first place, that buildup of those proteins, has proved incredibly challenging in science. And hopefully there will be a breakthrough. But right now, I think that it's still a pretty uncertain landscape when it comes to that. So I'm going to stop sharing my slides, and that'll conclude my comments on this question, Joe.
Jim, I so appreciate it. That was great, just great. Before I turn to Dr. Busker here, quickly to our panelists, if I get questions through the Q&A, which I'm trying to answer myself, I might, every once in a while, I might direct some to you through chat. So John, for example, I got a good question through the Q&A that I directed to you in chat. Feel free to respond to me or respond directly on the Q&A tab, and that would be great. So, all right, well, this has been tremendous so far. Again, I want to turn to Dr. Busker to hear her address her question of interest. And Amy, I'm going to share your slide for everybody, and we're all set to go.
All right, thanks. So the question that I am answering is, what medications would you most recommend someone living with dementia not be taking, including prescription and over-the-counter or herbal medications? And this is a great question. It's a very important question because there are many medications that can contribute to confusion or impaired cognitive functions. So we certainly want to try and avoid these medications in patients with dementia. So one of the big classes that really red flags go up for us is when we see the anticholinergic medications. And this is because these medicines reduce acetylcholine, and Dr. Birkeland did a great job explaining how that works. But these medications reduce acetylcholine activity, And many patients with dementia, as you heard, already have a reduction in acetylcholine, which is an important neurotransmitter and for memory and cognition. So some of the common anticholinergic medications that we see that are concerning that can increase the risk of confusion, memory issues, impair cognitive function include antihistamines, and namely the first generation antihistamines, so the older ones like Benadryl or diphenhydramine and hydroxyzine, for example, which of course these are commonly used for allergies or itching. I do want to point out too that there's a lot of, it's important to be aware of the combination products out there. So for example, I've had people coming to me who have concerns about their memory and they're taking Tylenol PM. Well, that PM is indicating that there's diphenhydramine in there, which again is highly anticholinergic and contribute to confusion. So we really do want to try and avoid those. Tricyclic antidepressants are another class of medications we need to be concerned about. These are actually, they're older antidepressants, but used more commonly we see for nerve pain or sleep. Amitriptyline and nortriptyline are examples of those. I should mention too that there's an SSRI, a serotonin reuptake inhibitor, that is used commonly and that we see pretty frequently, Paxil or paroxetine, which is highly anticholinergic. And that is another one that concerns me when I see that. I usually try to do ones that are not, I try to avoid those highly anticholinergic medications in our patients with dementia. So that's a good one to be aware of as well. And the next class that we see a lot of are the GI or urinary antispasmodics. So, I mean, most commonly we'll see oxybutynin or tolterodine, which is Detrol for overactive bladder. Not very effective medications either, but can certainly contribute to confusion and memory issues and cognitive concerns. Antiemetics for nausea and vomiting, such as prochlorperazine or promethazine, are some examples of those. Muscle relaxants like cyclobenzaprine, with the other name for that is Flexeril. That's another one to be concerned about as well. I don't know if that's popping up for you, Joe. Let's see. Thank you. And then there's some anticholinergic, anti-Parkinson's agents as well that we just need to be aware of. Some other medications that should be avoided if at all possible, just to their increased risk of central nervous system adverse effects, and such as confusion, delirium, impaired cognitive function. And should mention, of course, that patients with dementia are going to be at even more, this is a concern with our older adults anyways for these classes of meds, but it's even more of a concern for our patients with dementia. They're more prone to experience these adverse effects. So the benzodiazepines, like lorazepam or diazepam, commonly used for anxiety or sleep, are ones to avoid if able. And then the benzoreceptor agonists, we hear them referred to a lot of times as Z drugs or Zolpidem. Other name for that is Ambien. So these hypnotic meds to help with sleep are concerning as well. And then opioids for pain. And so this, of course, is not a full list of medications, that can contribute to cognitive issues. But certainly if you have questions or concerns that your loved one might be on something that could be contributing to cognitive decline or memory issues, then definitely ask your provider, ask your pharmacist, do regular medication reviews. It's so important. I know I went through that really fast, but I think that wraps it up.
Amy, I know we talked a couple of years ago, and you had given this stat that was just blew my mind about the person. There was someone you saw that was on like an astronomical amount of medication, and I think like that might be something that the people would like to hear about. Because speaking of medication reviews and the importance of that.
Yes. Oh yeah. No, it's not uncommon to see people on, I would say the average number of medications for the people that I'm seeing is probably 15 to 20. It's a lot. And so, just that alone is concerning, and certainly need to be looking and making sure people are only on what they really need to be on.
Yeah, I feel like the number we were talking about for the most was like 32 or 36. I mean, it was.
Yeah, I've had patients definitely on that much, but that's fortunately not the average number that I see. But yes, I see that frequently.
Well, thanks, Amy. That was great. Great quick overview. Really appreciate that. I'm going to turn to Dr. Gustafson next from the physical therapy perspective and the question that she chose to answer. And Allison, I'll share your screen too. Let's get that up here. Okay.
All right. Can you guys hear me? Thanks, Joe. So yeah, the question I chose was from someone that asked, how do you balance the loss of reasoning or cognition with letting the person feel that they're still valued member of the family and can still contribute? And I just want to thank this person for this question. I think this is a question that comes up a lot in my practice. So when a loved one is diagnosed with dementia, often the focus really shifts towards health, towards safety, and kind of basic care needs, with less attention on your loved one's role as a member of a family, as a friend, as a participating contributor to society. So this loss, the loss of this role has implications for confidence and self-esteem. So preserving or modifying a loved one's sense of purpose really becomes imperative. And in this sense, I'm thinking about purpose as like having a meaning or direction and a feeling that life is worth living. So how can we invite and reinvent that purpose? And I'm just gonna outline a few tips to help with that. And the first is really understanding what is most important to that person with dementia, what matters most to them and gives them this sense of meaning and direction. And then the second is to ask for their help. Recognize and acknowledge that, something may have been a role that they used to do independently and they can still contribute. So for example, if they used to wash the dishes, maybe there's a way that they can still help with that. And just to remember not to be harsh if the results are less than optimal, just kind of focusing on that process and giving them that sense of purpose. The third thing is really involving the whole family and the circle of friends and the social network. So individuals with dementia are often drawn to intergenerational activities, and this gives them an opportunity to connect and listen and be heard, which again kind of builds into this purpose of and sense of meaning that they might have. The fourth thing is really playing to their interests and hobbies. So looking for meaningful activities that make them feel useful and good about themselves. For example, if they used to do all of the cooking, maybe having them help with an aspect of the food preparation that is safe and within their abilities. And then finally, really to just listen and kind of take that space to just listen. A lot of times, as we talked about before, they retell stories or many times, but just kind of setting some time aside to allow that person really to tell that story, to relate it to what you're saying. And, regardless of what you choose, these activities should really aim to stir memories and allow your loved one to reminisce, foster emotional connections with others, encourage self-expression, promote independence, and then in all helping them feel useful and actually having them be useful in your life. So that is kind of what I had. So thank you.
No, thank you, Allison, so much. Such a great slide too. I'm going to be excited to share that with everybody. Thanks, Allison. And let's turn to Jill. Jill, I'm not sure if you had a slide for the questions you were planning to address. But please take it away.
You know what? I'm going to just share the slide I ended on the last time I shared slides, because I think it's it's relates to the question. So the question I'm going to answer, somebody inquired about what changes can we make around the home to make the home a more supportive environment for a person living with dementia. So that's a great question. And I think what immediately comes to mind for people is physical accessibility. So we think about stairs and bathtubs, and physical accessibility is really important. And it's a big piece of what we can do to make home a safer environment for a person with dementia. But dementia accessibility is really about sensory accessibility. So we like to think about the brain as the sensory processor for the body. So it's really about making the processing demands for the brain easier. So the things that you can do to make a home more supportive and more functional for a person living with dementia are things like reducing as much clutter as possible and simplifying environments. Let's take a bathroom vanity, for example. So the caregiver, let's say the wife might ask her husband to go brush his teeth. Well, if the bathroom vanity is full of 10 tubes of white cream, as you can imagine, most of our bathroom drawers and cabinets are, it becomes very difficult for the person with dementia to think through, okay, what are the proper items I need for this task? What was I supposed to do? I'll brush my teeth. There's 10 tubes to select from. Which one is the toothpaste? So all the things that we might take for granted when our brain is working well are things that are challenging for a person whose brain is not working well. So the most important thing to do is to reduce clutter, simplify spaces, and provide visual cues. So a visual cue is something that helps a person know what task they should be engaged in, or know where to find an item that they might be looking for. A visual cue can be something as easy as putting a picture of the toilet or a sign that says bathroom near the bathroom door. Or on our toothbrushing example, it can be clearing off the bathroom vanity of everything except for a toothbrush and toothpaste. And then it makes the task of oral hygiene very simple and straightforward, and the person can probably complete it without any reminders or help. So you really set a person up for success and independence. We also think about safety. So we provide things like door alarms if there's a risk for wandering, so that a caregiver in the home could be alerted if a person is leaving through an exterior door. Or you might know that rummaging is a activity that a lot of people with dementia may, in moderate to later stages, engage in, which is just kind of going through belongings or cabinets or drawers. And it's a normal dementia behavior, because people are looking, like Dr. Gustafson just mentioned, for that sense of purpose. But sometimes they lack the direction to know how to purposefully engage. So if there are places where they shouldn't be rummaging, like maybe where the medications are stored, or where dangerous cleaning products are stored, or where the bills and really important paperwork is stored, we'd like to secure or lock those areas, and then leave places that are safe for rummaging, maybe the linen closet and the silverware drawer, open and free, so that a person does have places where they can sort through items and feel busy around the house. We like to encourage a lot of safety thought and consideration in the kitchen. So things like disabling appliances if there's a risk for somebody starting a kitchen fire, or if they shouldn't be using the microwave, the stove, or the oven, there are ways to disable those appliances when it's no longer safe. There are also great pieces of adaptive equipment. So simple things like shower chairs, tub transfer benches, to improve the bathing routine. We also like to recommend handheld showers, because if you do need a little assistance with the shower, having a handheld shower makes it easier and safer for the person with dementia and for the person who is assisting them with the bathing activity. And you know what, I'm also going to drop in the chat box a link to a video tour. We have a dementia training home. It's a bedroom, bathroom, kitchen, living room, where it's a short video that I'm happy to share, and you can walk with me through our dementia home and kind of see some of these modifications in action. But what we like for people to know is that it doesn't have to be expensive, major home renovations. There are simple things that every family can do around their home to improve safety, to reduce clutter, to provide more visual cues, and to really set a person up for success with their daily activities around the home. And there's a lot of fun technology right now. Our families are really enjoying things like the Amazon Show, where you can drop in a FaceTime call. So a person with dementia doesn't have to remember how to use the FaceTime feature on a smartphone. That might be too complicated, but through a device like the Alexa Amazon Show, you can just drop in a call, and it's passive technology for the person living with dementia. So it especially during these COVID times, has reduced a lot of feelings of social isolation when there are ways that are simple ways to use technology to connect with loved ones who are living with dementia. So between adaptive equipment, some fun technology, a real focus on safety, and simplifying the home environment, any home can be transformed into a dementia-friendly space. So I would say back to my slide that it's a really nice summary of some of the panelists who have spoken previously. Dr. Birkeland talked about those communication strategies. So that's part of our care approach. You know, what families kind of wish they could change is the person living with dementia. They wish they could take away the dementia. They wish they could explain themselves enough, and so that the person with dementia can understand. And those, unfortunately, are misguided. You know, but there are a lot of things that are within our control, and those things are that we can, people around the person with dementia, whether you're a family member, a friend, a paid caregiver, a healthcare provider, we can change our communication, and we can change our approach to care. We can change the environment around the person living with dementia, some of the strategies I just mentioned. And as Dr. Gustafson mentioned, we can change, simplify, modify the tasks and activities that we are expecting the person with dementia to engage in. So this is really what behavioral dementia treatment is all about. It's about teaching family members and friends how to go through problem solving and brainstorming to find these things we can modify to make life better for everyone. I will leave it there.
Great, thanks, Jill, so much, appreciate it. Right, well, I mean, oh, did someone else have a comment? Sorry. So, yeah, well, just great, all of this content. I mean, 90 minutes have already passed, and I mean, it's going so quickly for me just because of the richness of not only the questions, but then also this great content that all our panelists are providing. So thank you. You know, I thought we could spend the last half hour addressing some of these other questions that have both been submitted, as well as those that are being submitted in our Q&A function. And one thing I'll ask our panelists to do is if you have a chance to go in the Q&A and address some of the questions, please do so. For example, I think Robin Birkeland, there's a good question in there that you could probably answer. Amy Busker, there's another good one for you as well. So take an opportunity to do that if we don't have a question directed to you, at least right now. So You know, I wanted to turn to you, Robin Fraser. A really good question came in, and I think others might be able to weigh on this one as well. How to help a person with dementia without family or a spouse to look after them? I think this is a great question. It's one that we don't always address, but should. And Robin Fraser, I'd love to hear your thoughts on that.
Okay. You know, I actually have some friends that fall into this. And so we talk a lot about the solo seniors, and they are often living alone without immediate family, or sometime even extended family right there with them to assist them. And so in that particular case, it's really important to identify if there are people that, the non-family members, but people that are a part of their circle of support. And so that might be people in their church. If they're residing in independent living, it might be people that are there. And it might be reconnecting with friends. But one of the things that we're doing in our network is we have formed, we just call it the family and friend circle. And none of us are biological family, but what we've done is we just have created a group for a person that's living in 55 plus housing. Right now, they can still live independently, and they're receiving food services, and they're going to activities. All of the arrangements are made for their doctors. And one of the things that we had to have with the person is a conversation around that there wasn't one of us that could do it all. And so we had to sit down and say what things, and figure out are the things that you can do, but then what are the things that are too difficult to do? And then we shared that across the group, and then different people pitch in at different times. And so I think looking to see if there are people that they're connected with, and getting them to kind of pull resources. Also, it may be looking at a different housing option so that they can move into housing that are going to have the support services if it exceeds what they can do. But those would be a couple of the things. I believe a lot in the chosen family, and sometimes people can be, particularly like in the LGBTQ community, they could be people that aren't biological family members, but they're just as close or even closer. And so sometimes it's with the client really exploring who all is in their life and what are the places and things that they're involved with to uncover what might be some of those hidden support systems. And then I'll open it up if anybody else would like to add to that.
Well, Robin, I might add from the legal perspective, this issue of solo seniors is also a challenge for us because all of the solutions to this issue of incapacity that I discussed involve the nomination of an agent, another person. And for many of our clients, there isn't a natural other person that they can just plug into a healthcare directive or plug into a power of attorney document. And so that's a challenge as well. And so sometimes it is just sitting down with someone and asking, brainstorming with them, who are the people that they care about. But I know that the Minnesota Elder Justice Center and Linda Camp have done a lot of education as well with this idea of a solo senior and creating networks. And it's a challenge. I don't have the answer, but I know that a lot of it hits from a lot of different angles, and it hits on the legal side too. And we sometimes don't have a person to plug into a document when we could be, doing a healthcare directive.
And I think also, I know with some people, the people that they've selected for their legal documents are out of town. And we've run into that. And it's so difficult if the people with that legal authority are out of town and you've got someone that's at the airport that's confused and they can't get through security. So that's where I've got a call and they're like, we're sending them to Hennepin County Mental Health. And I'm like, no, give me time. I will drive to the airport as soon as possible. And so, you know, with the person and people that we work with, you know, identifying somebody that is comfortable with that role. And sometimes it's going to be different people, some on the legal side, some on the financial, but identifying those people and making sure that they are local and can make real-time decisions because things happen so quickly.
All right, that was great. Thank you, Robin. Thanks, John. You know, for this next question, I'm going to direct this to you initially, Dr. Picala. And again, love to hear if other members on the panel want to share their thoughts. When to bring in a geriatric care manager and how to make that relationship work optimally for a loved one with dementia, their spouse who needs help with things, and the larger family working to support them. I thought it was a really interesting question. Love to hear what you think, Jim.
Yeah, it's really important. I spent several years studying what back then was called case management, and then it was called care management. Now it's called care coordination. It is extremely effective for people with complex medical and social needs, particularly if there are numerous different conditions. So I think it's important to be selective if you are a family member with what type of care coordinator that you need. If your loved one has Alzheimer's or another type of dementia, but is relatively free of other illnesses, then having a specific care coordinator who specializes in dementia would make sense. If you have a loved one who has dementia and also has heart disease, osteoporosis, had a hip fracture, and several other medical conditions, and they're living by themselves with a patchwork of friends and family checking in on them. So there's lots of social factors involved in their care as well. Then a more general geriatrics care coordinator who is familiar with multiple chronic conditions and lots of a wide variety of services is probably a person that would be better to bring in. So care coordination is really helpful for complex single diseases like dementia, or even more so for a constellation of chronic illnesses and non-medical or problems or social conditions that can impair good health care. And so if you're in a situation where a doctor tells you, oh, well, go and do this, go and get some therapy, go and see a neurologist, go and, and you don't know how to do that, or you're struggling, that's when you need to get in touch with your primary doctor and say, hey, I really need a care coordinator here. I need somebody to help me navigate this, because it's impossible for folks to understand. I don't even understand it, and I'm in the medical system. So I would say that the more complex the patient, and the more that you're struggling with how to do something, that's when you would want to seek out a coordinator.
Thank you, Jim. Does anyone else on the panel want to share any thoughts or insights to that? Okay. Here's a question that came. I'm going to direct this to Dr. Birkeland, and there were different variants of this question, both in the chat as well as that were submitted before the event. So how do you recommend getting someone to a pre-scheduled appointment to be evaluated when they think they are fine? This came up a few times, and we'll start with Robin. I think others might have some insights too on this one. So.
Yes, that is a tricky one. Our recommendation is to kind of meet them where they're at in a way that see what you can kind of get the foot in the door type of technique, where like if they're willing to go to a doctor about something else that may be bothering them, then you at least are getting them there, and maybe it can come up in conversation when you're there with their primary care doctor. Or if they're willing to kind of go with someone, maybe they're not willing to go with you. Maybe that's part, like a lot of times if a kid, an adult child is the one instigating things, it can be a little bit more of a, no way am I letting my child tell me what to do here. So maybe there is a sibling that they would feel more comfortable going with, or a friend, or like if there's somebody that you can find is their person that they would be more willing to do that with, that could be a way in. But it is it's hard to force someone to go to something they don't want to go to, especially when you don't have those tools of being able to say, hey, think about this, let's just think this through and kind of bring out your rational, logical argument, and they're not going to be able to process that, and they're going to dig in even further. So, it leaves you to kind of know, based on who you know, how they are, and like who their people are, you might be able to find a person that they would be willing to go with. You might be able to just get them to go to a regular scheduled doctor's appointment that is not about memory. And then, you can provide the doctor with some information beforehand, or you can just see if they pick up on something there. But, that's hard because people are really good at covering when they need to. So it may be hard for someone to pick that up if they don't have some information beforehand. I'd be interested to hear what other people think as well, if they have something that has worked very effectively.
Any other thoughts from our panel on this one? That's a tricky question.
I agree with all of Robin's strategies. And I think there's no one size fits all answer, as she mentioned. So it's about, and a lot of it is about the severity of the impairment, because there are strategies you can use. For example, if you know a person's short-term memory is very poor and they're unlikely to remember that the appointment's coming up, what we often tell families is not to announce any appointment in advance, if you can avoid it, because sometimes for a person who can't remember when the appointment is, can't remember why they're going, but they know they have something coming up, it creates a lot of anticipatory anxiety. So we tell families, just don't advertise in advance, because a person with dementia, really one of the few gifts of the condition is that they are living in the moment. And so they probably, if you can live in the moment with them, and maybe your outing to the doctor is you're already out doing other fun, enjoyable things, and then you're going to swing in the doctor's office after you've had a nice lunch together and like, oh, I think we have an appointment here. I can't remember if it's for me or for you. Let's go in and see. That is not a strategy that works for people who are very early into having problems. But oftentimes, when you fill out your annual paperwork at your doctor's office, you generally indicate who the office can communicate with about your care, and it's usually your spouse or your adult child. So we encourage families to call, like Robin mentioned, call ahead, and just, if you're one of those people who are approved to talk about the care of your loved one, call ahead and share your concerns before that appointment, and just wait for the next annual appointment. Don't make it about deficits. Don't make it about that you're saying, oh, there's something wrong with you. Make it about the next annual physical, and you've already prepared the doctor in advance about a concern you're having. And another thing, there's no problem with, doctors can't communicate back with you because of privacy and confidentiality reasons, but there's nothing precluding a family from communicating with a physician. They don't have to read it. They don't have to consider what you've said, but don't hesitate to send a written message or a phone message in advance of a family member's appointment if you have a genuine concern and that concern is in their best interest.
And
I would, yep, go ahead, Robin.
Okay, I was going to say, and one thing you can do is if they have a physician or someone in the office, it might be one of the medical assistants that they're close to. One tactic can be to have them actually call the person and say, I haven't seen you for a while here, Claretta, and we're going to check you head to toe. And then they cover the routine things, and then they can share. We're also talking to our families about memory loss, and most people don't have Alzheimer's or dementia. It's a small piece, but we want to check in on everybody because we want them to be independent. And so that can be another way to connect them, and actually they can initiate that call.
Yeah, I would just say that I call it getting them in by the side door. And, as a geriatrician, I encourage families who call me and say, I want to bring them to you. I can say, I'm a specialist in taking care of older people. And, you're 75 or you're 80, so you qualify, and and then I get them in, and while they're in there, then I can do a cognitive assessment. I do often get furtive notes, phone calls, messages, texts from family members saying, you need to know this, or I've made an appointment for my mother to come and see you, and you need to know this because she's not going to share that with you. That happens quite frequently. So you can come in and address what's on the patient's mind, but then at the same time, then you can follow up with the concern that their family member has indicated to you.
Okay. Thank you, everyone. That was great. Wonderful. Here's a question. I'm going to direct this one to you, Dr. Gustafson, but I think, again, others on the panel likely will want to weigh in. How can family keep someone with Parkinson's related dementia active and engaged? Seems to have so much drowsiness associated. So, and we probably could extend this answer beyond just Parkinson's, but Allison, what would you like to share about that?
Yeah, and I think, even when you just remove the dementia part, the part of the Parkinson's, just the pathology is making them that drowsiness, it could be contributing to that. And then you layer some of the dementia on there. And I think this just goes back to kind of what I was talking about earlier about like finding what is meaningful to them and trying to engage in that perspective and really kind of meeting them where they are. Is usually just like the best, like some of the strategies that I mentioned earlier. I'm trying to think if anyone else has anything else, please jump in as well. That's what I'm thinking at the top of my head here.
Yeah, what do others think about this question? And again, ways to, enhance or maintain activity.
It can be a challenge. There are exercise programs now for people with Parkinson's disease that have been shown to be quite beneficial, and they can be individual or group. Now that's for a patient with Parkinson, but not dementia. And that's another thing, you can get them confused. Somebody with Parkinson's disease who doesn't have dementia can appear demented, and you've got to really formally test them to figure out whether they've got it or not. Usually they don't, but if they do, that makes an exercise program can help with alertness and can help with energy. That's challenging because you're teaching them new things. You're teaching them exercise and you're teaching them new routines. And so that takes an extra effort to be able to teach caregivers who can help keep somebody engaged in a physical activity or an exercise program. But I've been surprised, I shouldn't be because I'm not supposed to be biased like this, but I've been surprised at the results that people with Parkinson's disease can what they can engage in terms of exercise. It's really quite impressive and what you wouldn't necessarily think. The other thing is a medication review. So you got to send them to Amy and make sure that they've gone through a thorough med reconciliation to look for drugs that could be making them drowsy.
I'm glad you brought it up because if you weren't going to, I was. So thank you.
The other things that I was going to add, thank you, Dr. Pikala, are kind of also thinking about using kind of the energy conservation, like when do they feel the best? This is common with Parkinson's. When do they feel the best? When should they do that activity? Kind of thinking about energy conservation and planning your day. And we kind of call them energy dollars. So like if you have a high energy, high cost activity, if you feel the best in the morning, have them do that. If you're going to go out and do errands or something like that. And then the other thing is to think about is sleep hygiene. So again, this is kind of broadly for everyone, but it's very important, especially with the Parkinson's and the dementia combination. So consistent bedtime, wake up time, turning off devices, limiting fluids about 1 hour before bed, and then limiting naps. Like naps are okay, but kind of limiting those to 20 minutes. And then also kind of thinking about delirium in terms of, having lights on during the day when it's time to be awake, engaging them in something so they're not bored and just want to sleep. So those were kind of the other things.
Great.
I was going to add too, doing things together is always a good thing as well. So if you have like the time, and again, find the time where they have the most energy and you use that to your advantage and do something with them so that, it's not just them doing the exercising or activity.
Great. Thanks, Robin. I think, given our time here, I'm going to close with this series of questions really to you, John. Like I said, we had a bunch of legal questions. And I got a bunch of them here, and I'm going to just have you pick maybe one or two to address, within reason. One, when does an estate go to probate? Does the elder law attorney represent their client in court? Can an elder law attorney help with developing a personal care agreement between mother and her caregivers, daughter's granddaughter? Can the elder law attorney explain, clarify, spend down? That's a good question. And then what should I be mindful of when filling out county forms for assistance? So again, that's a bunch of questions, I know, but if you want to pick one to focus on here for these last few minutes, that would be great. So
yeah, I guess I'll touch just briefly on the spend down question, the county benefit question. That comes up a lot, and this category of elder law, I really think of it as encompassing two different things. One is this issue of incapacity with guardianship, conservatorship going to court, and the other one is how do I pay for the long-term care, the nursing home, the assisted living, the memory care, et cetera. And just at a real high level, people have different kind of concerns about someone's going to take away my house, someone's going to take away my money. I don't want to lose these things. And it's not a question of anybody taking it away, but it is a question of completely depleting your own assets. And so if I were to be in the nursing home, I can apply for, in Minnesota, what we call medical assistance, but at a federal level is Medicaid. And by the way, these are all state by state rules. Each state can establish its own eligibility within certain federal boundaries, but I'm required to completely diminish my own assets down to $3,000. And so if I am in a care facility and I'm getting a bill every month, I have to pay that bill. And it doesn't matter where the money comes from. If I have to sell my residence in order to pay the bill, then I have to sell my residence. If I have to sell the cabin up north in order to pay my nursing home bill, I have to sell the cabin up north. And so I am not eligible for these benefits until I have completely gone through my own assets. And that's a glass half full, glass half empty scenario. I think the glass half full is that it's wonderful that we have a safety net. Before we had Medicaid, the almshouses were full of poor, impoverished seniors, that we essentially had a homeless shelter style system for dealing with impoverished people who were aging and didn't have family that they could live with or care with. So this is a good thing. But on the glass half empty side, it's creating an incredible burden every generation to have to spend our assets down to $3,000. And I think creating a cycle of poverty on a generational level, that we have home ownership that we are losing every generation because we have to sell it to pay for the nursing home, and no one can reap the benefits of the prior generation's hard work. So I really see it on both sides, Joe, but the short answer is, you just have to sell everything, liquidate what you have, and then you're eligible.
Great. Thank you so much, John. Any final closing comments from our panelists here before we adjourn? This was just tremendous for me. I mean, I've enjoyed this so much, and not because I didn't have to speak necessarily either that much. I was answering a lot of questions in the Q&A box, but really when I had all these questions come in, I mean, what really struck me was not only the breadth of the questions, but the depth of them. I mean, these are challenging issues. These are issues that require really people with multiple types of expertise to address. And that was the purpose of this panel. I feel like we accomplished that in large part today. And we're just so thrilled to have you here. So again, we will be sharing with you the recordings and slides. I have a final slide myself I wanted to share with you of just some contact information. So again, this information, in addition to us emailing it to you, will also live on the Minnesota Northstar Geriatric Workforce Enhancement Program website. There is an email there, and I apologize, I thought I had put the website up here. The website is easy to remember. It's basically mngwep.umn.edu, very similar to the email address. Again, if you'd like the website, we will share that with you in a follow-up email. Also, there's a Twitter account and phone number as well. Also, at any time, you can contact me directly, and I'm happy to share with you any information, any other resources that we have available. So again, thank you to our wonderful panelists here today. Thank you to you for the great questions that you've posed and for being here today. We hope to hold another Minnesota GWEP event soon. I would imagine by the end of the summer, September-ish. But again, be on the lookout for that. We will be in touch with you. And again, have a great rest of your day. And thank you to all the panelists. Really appreciate it.
Thank you, everyone.
Yeah.
Thanks, everyone. Take care.